Hi, Dr. Rachel. Dr. Warigya.
Yes, Emily, hi.
Ah, Glad you can hear me. Hi, how are you?
Fine, thank you.
Yes, we can see you, we can hear you. Allow me to call you and say something. And then as we wait for Dr. Mutinda.
Hi everyone and good evening. I see quite an come all. Uh, I believe that we are all looking forward to having a wonderful discussion. Welcome, Dr. Mutinda. Already shared your script. Yeah. So once again, welcome to today's webinar on advancing palliative care in Kenya, research and evidence. My name is Rachel. Uh, I work in palliative department current third year at this university.
Oh, hello, Dr. Waringe. Is it me who is breaking? Is it my network which has a problem or is it yours? I don't know. But I can hear that you are breaking. Can you hear me clearly?
Yes, I can.
Okay.
I think
All
it's
right.
Dr. Rigia breaking a bit.
Oh, okay. So can you see my presentation?
Yes, I
Yes,
can.
we can.
Okay, sir. Thank you.
Doc,
So,
Doc,
yes.
just a minute. Dr. Wariga has a brief introduction about you, and then you start.
Oh, sorry. Thank you. Thank you.
I hope, am I audible?
Yes.
Yes.
Emily, am I audible?
Yes, you are, Doc. You can go ahead.
Uh, Dr. Justine Mutinda is going to take us through to Dashon. I believe we all understand that we have a great palliative care in Kenya. Have a rise number in the patient diagnosed with an uncommunicable illness. So I believe Dashon we shall be able to see how we can translate research evidence, even as she'll be encouraging us on keeping good data. Beautiful, amazing work wherever we are, but the evidence we are doing as we continue acting, many other people are in it. So welcome Dr. Justine Mutinda. Bio on her. So she's a distinguished palliative care expert, a nurse, and also
Okay. Dr. Rachel, I can't hear you, but maybe I'll assume that you are done.
Yeah, yes, she's breaking. Allow me to just read Dr. Mutinda's profile, and then I'll hand it over to her. So Dr. Justine Mutinda is a distinguished palliative care expert, a nurse academic, and a researcher recognized for her pioneering contribution to the advancement of palliative care in Kenya. She's trained as a nurse and she has built an outstanding career dedicated to improving quality of life for patients and families facing life-limiting illnesses. Happy to say that she's the first Kenyan to attain a PhD in palliative care, which is a great milestone that has significantly strengthened the development of palliative care in Kenya, and also research education and evidence-based practice in Kenya. And Dr. Justine is a lecturer at Kehpca, where she actively trains and mentors healthcare professionals, contributing to capacity building and growth of palliative care. So Dr. Mutinda, karibu sana. We look forward to really learning from you in ways where we can advance palliative care in Kenya. Thank you.
Thank you for that kind introduction. Allow me now to mount the presentation. I hope it is visible. So our topic for today is advancing palliative care in Kenya through research and evidence. And just a brief introduction regarding the topic. Yeah, we are all in agreement that as palliative care continues to grow.
Dr.
Sorry?
Justine, are you
Can you see
able to
that?
put it? Are you able to put it on slideshow?
Is it okay now? Hello?
No,
Is it in
no.
slideshow?
Try again. No.
Oh, okay. On my side, it's in slideshow.
Okay, you could stop
Unless I go to the
sharing.
book.
Then you could stop. Then try again.
Okay, fine. Let me try. Because on my side, it's showing slideshow. Oh.
Well, just start out in the course of the discussions in the chat, and at the end,
And now?
have a segment for questions. And
Yes. Now it's perfect.
Okay. So I just started by saying that as palliative care continues to grow, and we are all in agreement that the needs for palliative care are increasing day by day based on the conditions that are being diagnosed and the growth of non-communicable disease burden. So we can say that palliative care continues to grow. So the need for strong evidence to inform practice, improve service delivery, and even influence policy cannot be overemphasized, because we know that as this field grows, we need now to build an evidence-based knowledge so that we can be able to practice from a point of evidence. Then that will improve the service delivery for the patients, and research will also inform policy in a way that we are going to discuss shortly. So building a culture of research and documentation is essential in identifying gaps, one, because when one goes into research, if you want to come up with a new innovation, for instance, you must identify gaps in the existing mode of practice, because we do not invent a new wheel. So through research, we identify gaps in the existing practice or knowledge, then we can be able to improve through the findings of our research. Then there is demonstrating impact and also guiding sustainable improvement in care for patients and families, because when you talk about palliative care, we cannot ignore the holistic approach about it. That is the social component to include the family, the caregivers, not just the patient alone. So again, advancing palliative care through research improves the quality of life for both patients and families of those facing life-limiting illnesses. And this is by creating an evidence base that informs clinical practice. We could be seeing or reading about what has been documented before about palliative care or service provision in the area of palliative care. But the question is it applicable in our setup, that is in an economically constrained country, or in a country whose culture has been shaped by many other things, including traditions, language barriers, and the rest. So we need to create an evidence-based practice based on what we have researched that can be applicable and that can improve the quality of life for our clientele. This reduces suffering and also optimizes care delivery. So the integration should be done early, and we all know that integration of palliative care starts from the time of diagnosis throughout the disease trajectory. So we start by looking at developing a culture of research. And I'll start by defining what is research culture. So research culture refers to the process by which research is conducted. That is openness meaning that one goes throughout the process of proposal development and through the processes of approval, that is ethical approval, and that is what demonstrates openness. Otherwise, if somebody would have gone to do plagiarism or to just bring up research findings from other people's opinions or other people's researches without looking at the ethical component, then that does not constitute openness. Integrity, also that ethical process will inform integrity as well as citing evidence from previous researchers. You want to recognize that this work is not my original work. It has been done by others. I'm citing their work as I go on to do my own work or to come up with my own document. So integrity is very important. You recognize the performance or the contribution of other people. Then collaboration, work in collaboration to be able to come up with a researchable topic or even to be able to come up with findings that can be applicable or acceptable in any setup that you want the resource to be implemented. And also how people experience the environment in which the search happens. That is the recognition for all contribution, how the people will experience the environment where the research has been conducted. So now we go into how. How do you develop a culture of research? Having defined what is research culture, how do we develop a culture of research? And one of them is through setting institutional goals. So this is setting goals which must be accompanied by a well-defined plan of research, success, evaluation, as well as any accompanying changes in compensation or incentives. So in this case, there will be important to set goals in any institution, whether a teaching institution or any other institution that has developed a culture of research. We need to set the goals. Why do research? Is it a prerequisite to promotion? So that's why we're talking about compensation or incentives that are given to those who participate in research. So there should be goals that one needs to accomplish in their culture of research. Faculty, usually in training institutions, faculty are given some goals in research that they should achieve for them to be able to move maybe to a senior lecturer or to professorship, and that is part of setting institutional goals because they are required to maintain scholarly activities, including conducting research, publishing their work. So those are goals, or rather what they should be able to implement in their journey to promotion. Then there is a training and support. What you've talked about is setting goals. Then there is training and support. So training and support can come in different ways, and one of them is a mentorship. One of them is a mentorship. So in mentorship, this is having the senior researchers work with the other people who are junior in the profession to be able to mentor them. Maybe a professor or a senior lecturer or any qualified lecturer, they can be able to work with a student, whether a PhD student or maybe another lecturer who has never supervised a student, and they mentor them. They teach them how to go about mentoring, what to look for, maybe in a student's thesis. So that is mentorship. You walk the journey with them when you're maybe the first supervisor and this person is a third supervisor. So that is mentorship. And there is also continued education, which now this is a formal way of setting the junior researchers or the novice to be able to gain some knowledge. You give them some knowledge through a systematic or uh, a formal way of education, like what we are doing here. If we had a webinar teaching people the research process, and then we get CPD points. So that is continued education. It's a formal way of doing things. Mentorship is long term. You work with a person for some time as you show them how to do research or how to supervise students. But continuing education is formal, whereby you engage maybe in a workshop or in a webinar like this one, then a person gets CPD points or otherwise. Then research funding support. There is need for support through funding of research. And this can be through winning of grants. You write a grant proposal, then you win a grant to be able to fund your research activity. Or it can be through direct provision. The university or the training institution or any other institution that engages in research can be able to provide funding directly to the members of that institution so that they can be able to finance their research. And then there is also another way whereby they can be able to allow them to use laboratories which are of high quality, and they can be able to enhance research activities. Then there is a establishment of research centers to support some training programs. I can give an example with our institution. We use Intromid as a research center, or Kemri, whereby people can go and do their research because we're in collaboration with them. So an institution, if it is able to finance, they can finance establishment of a research center, or they can sign a memorandum of understanding with an existing institution that has a research center which can be able to support the research programs. Then recognition of research activities. And this can happen maybe by publishing the names of the people who have excelled in research in their journals, the journals of the institution, or even recognizing them. Maybe there is a graduation ceremony and the person is recognized, or they are given honoraria, which will help them now which will boost their morale to continue doing the research activities. Then there's also networks and collaborations. These ones can both be national or international, collaborating with other institutions nationally or internationally to be able to advance the field of research. And these collaborations, these networks can also be in conferences. For example, the conference we had organized by Kehpca, there you'll be able to network with other people. And it's a learning platform for those who are doing research, because you get to study with, or to be able to understand what other people have been doing in the area of research or in the field of palliative care. So networks and collaborations are also important in advancing palliative care research. And we also need to look at the key areas of research in palliative care. The key areas of research, there are some that have been, where research has been very actively done, and there are other areas that tend to be ignored. And there are also upcoming areas, for example, the telehealth and technology, which are yet to be populated with the research documents, or research has to be conducted in those areas in the near future. So the areas of research, we can look at the impact of early integration. We have just mentioned that palliative care should be integrated from the time of diagnosis through the disease trajectory, and even up to the end of life care. So one can research on this area. What is the impact of early integration of palliative care, maybe in children diagnosed with cancer, or in old people diagnosed with dementia? So that is an area that one can research on. Or telehealth and technology, because this telehealth has been noted to be of great help, especially in taking care of patients who could be having problems with movement, and it reduces that stress of a patient moving from home to the hospital every now and then, because they can be able to receive the instruction, or you can be able to follow up the patient. You can even have a video conference with the patient when they are in the house, unless there is need for them to come to the hospital. You can do a follow-up care using this technology by holding a video conference, even a family conference with family members. And that also encourages the family members to be able to participate in the care, because there are no strict restrictions that we find in the hospital, whereby somebody is allowed to visit, maybe only 2 relatives can visit at a go, and the visiting hour is 1 hour per day. So when you want to do family conferences, you can use the telehealth, and that will be of importance. It will both be time saving and also saving on the cash on the part of the patient. Social and the family support is another area whereby palliative care research can be conducted. For example, caregiver support of the family members, support of the patient who has been diagnosed with a life-limiting illness. It's another area which you can research, and also ethical and legal aspects. We know that there are so many ethical and legal aspects that surround palliative care, including the end-of-life care. So this one's one can be able to research maybe ethical dilemmas that affect nurses who are providing care or doctors who are treating patients who are suffering from life-limiting illnesses. Then structures and processes of care. This one include models of care. And in my PhD research, I developed a model of care for patients who are on opioid analgesics. So it can also be a rich area for research, models of care, and how they can affect or how they can improve the outcome or provision of a palliative care. And then physical symptom assessment and management. This is also an area that cannot be overemphasized. Symptoms management, that is management of pain and other distressing symptoms, because you want to assess maybe how applying a certain tool or a certain model of symptom assessment and management improves the outcome of the patient, and whether there are challenges or barriers to accessing this tool or utilization of the tool. So it's another area that one can engage in research, and also psychological and emotional care of both the patient and the caregiver and also the family members. Spiritual and existential care can also be researched on, because we know that the four domains of palliative care include the psychological, the physical, the social, and also the spiritual domain. Again, this area of spiritual and existential care is one area that has been under-researched. So it can provide a rich site for research. Then communication and decision making. There are many decisions that one needs to make, especially when they are at the end of life, and that can also be researched. Then strengthening evidence generation. Strengthening evidence generation can be done through quality research, and this is by ensuring high quality studies. High quality studies involve conducting research by meticulously following the steps of research. I mentioned earlier that it would be wrong for one maybe just to go and plagiarize a document and assume that that's their original work. That is not high quality research. So this high quality research involves identifying the right topic in collaboration with others, either supervisors or the stakeholders, then going through the entire process of approval and conducting research, analyzing the data in the right way. So it involves an appropriate design and then rigorous methodologies and addressing evidence gaps. Because one can conduct research, then you are asked, so what new thing are you bringing on the table, or what new thing are you bringing to the field of palliative care? So addressing evidence gaps is a form of justification for your research. Then stakeholder engagement and collaboration. So developing agenda with input from stakeholders, whether they are policy makers or whether it is the community, you can develop the research agenda with their input, because that one will facilitate the buy-in, whereby these people will accept to implement the findings of your research. For example, if it is in the area of policy formulation or policy change, if you consult with the stakeholders first, then they'll be able to take up or accept the findings with ease and be able to implement them. Then capacity strengthening of researchers to engage in policy-driven research, including training on evidence synthesis and policy translation. So there is need for capacity building or capacity strengthening, whereby people are they are either mentored or they are taken through continued education to be able to strengthen their knowledge base in research so that they can be able to, because that is the only way that it can lead to policy translation. So the other question is why? Why strengthen research or why engage in research in palliative care? So the impact of translating findings into meaningful improvements in palliative care will inform our why of implementing research findings or why of engaging in research in palliative care. And one of them is impact on practice. And in impact on practice, we talk about empowering healthcare workers. Empowering healthcare workers. These are now the formal workers who have been employed in the health sector, or they could also be informal caregivers. Informal caregivers are the caregivers who are not paid. Maybe they are relatives or just volunteers who are coming to provide palliative care. So research evidence can be used in empowering workers, and also improving they are empowered through provision of evidence-based knowledge. They can be able to get the research findings and apply them in their day-to-day provision of care. Then there is improving quality of care, and then improving quality of care. This one it is applicable in cases where a new way of provision of care has been discovered through research. And this new way of provision of care can be applied, and then if, for example, one was doing a pre-post kind of research, whereby you start with this group, then you assess the type of care that they have been receiving. Then you implement a new type of intervention that has not been in place. Then at the end, you assess the outcome of the care. Or maybe you have a post-experimental study where you have two groups. One is the interventional arm and the other one is the control arm. Then you provide the quality of care to this interventional group, and then you assess the results. So the end result could be improved quality of care, and that has come as a result of research. So research can bring a positive impact on practice by improving the quality of care. And this one has happened. We have come up with models like SSR that have improved the quality of care for patients in terms of assessment and symptoms management. Then enhancing cultural competence, because when one is providing palliative care, researches have been done to be able to assess the impact of culture on provision of palliative care. And that one has enhanced cultural competence, which is an integral part of provision of palliative care. Then impact on healthcare policy. So there is evidence-based policy development. For example, studies on benefits of integrating palliative care into UHC. So that is evidence-based policy development. One conducted research on integration of palliative care into UHC, and that one led to improvement of policy, whereby now the UHC has recognized the need for covering maybe palliative care or financing palliative care through SHA and other health-related financial initiatives. Then workforce development. This is policies that promote training for health professionals in palliative care, and this can be based on research, because the research findings can be able to identify gaps. For example, where there are no palliative care units or where there are palliative care units that are not well staffed. So this one can promote workforce development by recommending for the workers who are in that institution to be sponsored to undertake courses in palliative care, and that can be able to improve the workforce. Then evidence-based practice where palliative care reduces unnecessary hospital admissions and it also lowers cost. Research has shown that this happens whereby when palliative care, quality palliative care is provided, it can be able to reduce the rates of hospital admissions because if the patient is getting quality care at home, then there are few chances of getting acute illnesses that will necessitate admission, and this will reduce unnecessary hospital admissions, and it also lowers the cost. We just talked about telehealth, whereby teleconferences can be done. That is also a way of lowering cost by using an innovation that has been shown to improve palliative care provision. Good as it is, palliative care has faced challenges as well. Palliative care research has faced challenges in Kenya, and some of these challenges, just like any other upcoming innovations, these ones have also affected research in palliative care. What we keep on saying is that people are very resistant to change. People say people are resistant to change. Why? Because they want to remain in an area of comfort, whereby a comfort zone. Feel this is how we have been doing things. Why change? Or people they fear change for reasons known to themselves. So one of the challenges is that translating research findings into clinical practice can be a complex process requiring collaboration among various stakeholders. Maybe if you went to Afya House, you'll find a lot of research projects or findings that have gathered dust in those shelves, not only in Afya House, but even in maybe other ministries. You find that there are many research findings that have been heaped there because implementing those findings is a complex process. It requires collaboration among stakeholders. It will also require finances. So it's a complex process. And that is a challenge in research, not only in palliative care, but also in other fields, because it can discourage the researchers. Then they wonder, I thought we came up with this tool, I thought we came up with this model, and if it was implemented, we could have been very far in terms of provision of palliative care. But then you find that implementation can take long. Another one is a brain drain. We do research, we teach research to our nurses when they're advancing their knowledge and also specializations in palliative care. But what happens is that most of them end up in diaspora. They go and practice outside there. So you find that what they could have done here, maybe taught their juniors or they could have participated in research, ends up being utilized elsewhere in other countries. So that brain drain can also be a way of draining out our researchers from the country, and that's a challenge. The insufficient funding. So despite proven benefits, funding for palliative care remains low, even in high-income countries. It remains low because you find that doing research may not be given as high priority as purchase of medicines, for instance, or paying workers to provide direct care. So research may be given a second priority or the last priority because we feel that we want to see what is translating to tangible results. We can see that this is happening. The patient has been treated and the patient is recovering or something. But for research, it can wait because it's something that is not of, it is not a life-threatening if ignored. There are opportunities. Despite the challenges, there is also a positive thing, opportunities that come up with conducting research in palliative care. And I would say that by leveraging interdisciplinary partnerships, because you know that palliative care involves a multidisciplinary approach. We have the doctor, the nutritionist, the nurse, the physiotherapist. They all form part of the palliative care team. So by leveraging this interdisciplinary partnership and securing research funding and embracing technology, researchers can overcome barriers and drive meaningful change in healthcare delivery. So when you are working together as a team in an interdisciplinary partnership, we will not find cases of opposition, somebody feeling that no, this research funding should have gone to this initiative. It should not have gone to nursing, should have gone to physiotherapy, because we are all working as a team and our aim is to improve palliative care and to benefit the patient. So we should, this one is an opportunity for us to be able to embrace. And once we embrace this opportunity, leveraging interdisciplinary partnerships, it will be able to help us overcome the barriers. And this one will bring meaningful change in healthcare delivery. Then education in specializations. I am in education and others here are also in education. In specialization like palliative care, home-based care. This one, the research is part of specializations. You cannot do a specialization in any field without engaging in research. So educating people or encouraging people to further their education or to specialize in palliative care, it will promote the culture of research. And this one will create the platform to increase the understanding, more understanding in the field. Because as you continue researching, you sharpen your knowledge in that field. And it's the field of palliative care for that matter. It also fosters a global network of research activities, enhancing ability to address challenges in palliative care with an all-inclusive perspective. When we go for international conferences or when we invite people from outside to come and join us during our conferences. That one, it fosters a global network of research activities. And we are able to, nowadays, the world has become a global village. We are able to understand what happens in other countries and what you can borrow from there so that we can be able to improve care for our patients. Because the end result is enhancing quality care for these patients who require palliative care. Hence, so what, or in conclusion, so I would conclude by saying that leveraging palliative care research in Kenya is recognized as a high priority to address the needs of an estimated 800,000 people requiring such services annually, with only a small fraction currently receiving care. So if we improve research, we'll be able to know what really do people need and what can we prioritize. Because instead of providing a blanket kind of care provision without caring what you should give as a priority, it would be better to do research and really understand in any community where there are palliative care needs, there could be unique needs for that particular community, which you can only identify through research. And that way, if you identify the specific needs for that community or people or that special group of people, you'll be able to reference on the few resources that you have to be able to provide adequate care for those people or to magnify the kind of care that you're providing because you are specific on what exactly they need. Then there is need to improve our services in Kenya, and one way is by reducing the brain drain, and this is through improvement of GOK policies on terms of employment, because it will start with the government initially, and then the private sector can also be able to borrow from the government once they realize that this is the policy on remuneration, for instance, and that one will aid in reducing the brain drain. Then we should also aim at ensuring that our practice in palliative care meets the global standards, and this will be a game changer, giving us a competitive edge both locally and globally. Because in as much as you are reducing the brain drain, we cannot stop completely people from practicing in the diaspora or going to practice in the outside, either in the US, in the UK. So since we cannot stop it from happening, what we should do is that we improve our research activities so that we can be able to provide quality education, which will enhance practice for the graduates, so that it can be able to meet global standards. And that one will be a game changer in giving us a competitive edge both locally and globally. If you go to, sometimes back, I went to South Africa and I found that there are some hospitals that are completely run by Kenyan nurses. Even in the US, you go and find, especially in Texas, there are some hospitals where you find majority, 75% of the nurses are from Kenya. So it means that they recognize the standard of training that we provide to our nurses, and we can improve. There is always room for improvement. And one of the ways that we must admit that this has been recognized, that our nurses have been recognized in terms of their skill and practice, is the establishment of an NCLEX center in Westlands. That was a game changer in terms of training or regulation of nurses going out of the country. Because we see now we are the second, I think, after South Africa. So it means that they value the kind of quality care that our nurses provide outside there. Then we need to translate palliative care research and service provision into tangible socioeconomic impact. And one way is try to enhance optimal performance in our patients. A person may not be able to provide or to be able to be productive like another person who is not sick. A person with life-limiting illness may not be as productive as a person who is not sick, but you can enhance their optimal performance. When research is conducted, we can be able to tell this is what we can do to provide quality palliative care so that this person can be able to do a few things for themselves, or they can be able to continue with their work without much interference in terms of maybe going back to the hospital or getting admitted on and off. So when we improve their quality of life, they can be able to perform optimally, and that one will not only improve their quality of life, but it will also be able to lead to improved economies and also reduce poverty. And this can be achieved by coming up with innovative ways of improving palliative care across the disease spectrum, and one of them is telehealth. So allow me to pause there or to end there, and then please may I get reactions or comments or questions? Thank you for listening to me.
Yeah, thank you very much, Dr. Mutinda. Insightful, wonderful, and for the reminders on research and impact on our day-to-day practice, generally in our practice, medical. No the chat box, but I invite you have any questions. But even as we start, kindly allow me to invite Dr. Esther Mui for a short presentation so that we can see how we are doing in terms of and as Dr. Peter has reminded us that one of the ways that research impacts practice is in terms of healthcare policies. We have the data. What are we doing about it? So Dr. Muinga, welcome.
Good evening. Good evening, everyone. I'll briefly take you through reporting. So kindly confirm you are able to hear me and you're able to see my screen.
Yes, Doc.
Okay, sawa. So from the Ministry of Health perspective, Healthy Aging, Palliative Care and Older Persons Division, we do take lead in terms of palliative care. And just building up on what Dr. Mutinda has shared in terms of research and why we need research, one of the easy things we have, or one of the ways of getting data is just by reporting within your facility or the institution where services are being provided. And why do we talk about reporting? Because this is how we will know provision, or rather the status of palliative care service provision, how well are they being delivered. We are able to identify gaps, and Dr. Mutinda has mentioned that even in the research, if we write proposals or look for grants for the same. And then finally, it's ensuring that the intended outcomes of improving patient quality of life, dignity, and well-being are achieved. So when we talk about reporting, there are key policy documents that are guiding our service provision. We have this new recent document, the Palliative Care Guideline 2025, that has 5 chapters, but I'm sharing it because chapter 5 talks about implementation, monitoring, education, research, learning, and innovation in palliative care. And this is where you would talk about what a successful palliative care service looks like, what are the key indicators that you would like you to monitor even as you provide services in palliative care. So based on this, we have currently about 123 facilities that are offering palliative care services, some within government hospitals, some in mission facilities, some in private facilities, and also standalone hospices that offer these services. But then in terms of data showing how much you're doing in terms of palliative care services, and remember, I've said this is one of the way you could get data to show you just monitoring service provision, monitoring patient outcomes, etc. So the palliative care reporting tool is one such item that we can use as palliative care professionals and providers. So of the 123 that are documented, there could be more facilities. 52 are actually reporting to the government reporting system. 6 of them coming from Bungoma County. So you can see the gaps. We have 47 counties, but 27 facilities are reporting, 52 facilities of this. So a key challenge is inconsistent reporting. And what does that mean? We are not able then to come up with data that is consistent, so that we say this is the burden of palliative care. These are the services that you are offering as a palliative care service provider. So just based on the few facilities that are reporting, this is just a summary of the total number of clients receiving palliative care. This is catering for the past 6 months, an average of about 300 patients per month. So you could see even from the 52 facilities reporting, some would have bits and pieces of the tool not filled. So the numbers listed, and we know the burden of those needing palliative care is about 1 million. So if you calculate 300 patients per month, it won't get you to 1 million. It means there's a lot of missing data, and of course some facilities not uploading in time. In terms of activities, we also look at things like home visits, referrals, mentorship, education. Some of the other activities you can also monitor as you offer palliative care services. So you can also see we have a lot of home visits being done by the facilities, whether government facilities or hospices. their home visits being done. And then there's mentorship and there's also a referral documented. But we feel it could be more, it could be better if all facilities were using the tool. So I'll briefly take you through what are some of the components of the palliative care tool that is available on the MOH reporting platform. It looks at general figures in terms of how many patients did you see that month, inpatient and outpatient, divided as male and female, and then also looks at how many were adults, how many were children, and then new patients who received services. Then for the new patients, it gives us also information on where did they come from, where are the referrals from, and then lists a number of conditions in terms of the general population of patients who are receiving palliative care services. It also has data on number of patients who died within the month because it's a monthly reporting tool. And then data on how much oral morphine in grams was used in the month, and if morphine was available all throughout or there were stockouts. The other key things we mentioned activities. So there could be education sessions, there could be mentorship sessions, referrals, bereavement support, daycare. So this you'll feel as appropriate. You might not be having all this being done within your facility, but question 1 to 10 would have most facilities filling in because you definitely see a patient and you'd be able to classify them based on what condition they have at that time. Yeah, so even as we offer services and as we document, we keep reminding ourselves that as we offer palliative care services, you're focusing on hope, on dignity and relief. So always ask yourself if whatever you're offering is providing relief, is a dignified way of taking care of the patient, and are you giving them the best that you can, even as you offer these services. So our call to action to us is first start with your own documentation within the facility, and then think of research areas that you can implement either as individuals or as facilities so that you're able to see what gaps are there, document what opportunities and progress have been made, milestones over time. It could be within your county, your country and beyond, because I see there are people who are joining us from out of Kenya. So it's something that we need to take into consideration, starting with reporting. As you see the patients, document and make sure you liaise with the records officers so that they upload the information to the system. And then at the national level, we are able to monitor and see what is the actual burden of palliative care and the service provision on the ground. I'll stop there. I hand back to the moderator. Thank you.
Thank you very much, Dr. Muinga. That great. Clearly, we need to show our work, and the only way we can show and share our work is that which we have documented. And for sure, the ministry needs the data. So it's up to us, the palliative care providers, wherever we are, document to show data as it informs very many things, not only in our different institutions, but even in the country and the world at large. Thank you very much, Dr. And I'm reminded on something that was shared during the 7th Palliative Care Conference that was held in February, where we were reminded of a cycle that research informs practice and practice inspires research, and research updates education, and education strengthens practice. I think that has been a recurring theme from Dr. Mutinda and also. So thank you very much. No questions so far, but I wouldn't want to leave anyone behind. You can raise your hand. Yeah, it's an open opportunity to share something then as you wind up. One.
Dr. Rachel, I could ask a question to Justine. Okay, so Dr. Justine, if you're able to give us practical steps of how you'd advise us to translate research into practice. You talked about research that is done, but then it's somewhere, or the data is somewhere, or the information. So what are some of the key things we could implement, either as providers or facilities, as the palliative care fraternity, steps we could take towards now implementing or now translating this research and putting it into practice based on whatever evidence has been generated, and maybe also from your experience. Thank you.
One way is to maybe use the research findings to enhance patient care, those who are providing direct patient care. And you can look at what has been researched on or the available evidence. For example, if we see that these patients who are towards the end of life, at the end of life trajectory, we cannot insist maybe on providing them with this kind of care. Maybe we say if somebody, for example, has open bed sores, we cannot insist on dressing these bed sores always because we want to prevent infection, because we can see that even if we exposed the bed sores and we did open dressing, that would be better for the patient and it will reduce discomfort. So that is why one way you can utilize research findings to improve practice. Or maybe in instances where we have found that nutrition has been seen to cause discomfort, for example, pulmonary edema in patients whose organs are dying slowly, they are at the end of life and they're not able to absorb, then instead of insisting on feeding this person and you know that this will not be absorbed, the person will end up constipating and facing a lot of discomfort at the end of life. What else can we do in terms of provision of nutrition to this patient? It has been researched that you do not overwhelm the patient with a lot of fluids or with a lot of sugary foods and what have you. That is still implementing evidence from somebody's research, and it provides quality care to this patient who is at the end of life, or a patient who is struggling with the life-limiting illness, or even the issue of telehealth that I've mentioned. It's a new innovation whereby instead of inviting our family members to come to the hospital, yet we want to prevent infection, yet we want to do cost cutting. Can we do a teleconference? And that will involve more family members at home, and it will be a way of cost cutting in terms of finances and in terms of time. So that is also a way of implementing research regarding the current evidence-based practice. It is also another way of implementing. Thank you. The findings.
Thank you very much, Dr. Mutinda, for the response. Muinga. Yeah, Triza Ireri, your hand was up. Triza.
Thank you very much. Good evening. Mine is not really a question, but a comment rather. Thanks to Dr. Justina for that highlight. And looking at what she has presented, I was looking at the areas that are ripe for palliative care research. And I was wondering whether now that we are networked in the forums that we have for palliative care, thanks to Kehpca, I was wondering whether we would be able to collaborate in research, just as units, or for those who are interested, if possible, we can be coordinated to come up together and look at the key priority areas for us as a country that would want to research on. Yeah, if possible, if again, even from the ministry, Dr. Mwinga, if possible, if we can have key priority areas for palliative care research, and then we collaborate as different people and institutions to carry out the researches. Over.
Yeah, that would be a good initiative because there is what we have as educators and there is what the person in the clinical setup has that we may not have. So when you do it in a collaborative way, it will enrich the research activity and also the findings can be more acceptable. Because when I mentioned about collaboration with the stakeholders, the clinical specialists or providers and the community are part of the collaborators. And as it is said, what is planned for me and without me is likely to be against me. So that one will improve the buy-in because we are all in it and we are participated in the same. Maybe to add to my earlier comments, I realized it was Dr. Esther was asking about what we can do in terms of implementing the research findings. As a policy maker, how you can utilize the research findings is maybe to get funding and ensure that this goes into policy. You see, this is something that has been discovered through research, evidence-based, and we can use it as one of our components in the health-related policies to be able to implement or to improve provision of palliative care. So it can be passed as a policy guideline to be able to improve palliative care. Thank you. Or you can also help in dissemination to disseminate in the health facility to the health facilities since you have more access to them, and that can be a good way of utilizing the findings. Thank you.
Thank you so much, Dr. Response. So there is one question, Alvin. How do we resolve the cycle of the clinicians should start the discussion of end of life or should be initiated by patients and the family members? Or of who should initiate the discussions on end of life? Question from Alvin Mudaki. Dr. Mutinda.
That's the practice. Okay, the discussion on end of life. This one, I think, based on our culture, on our African culture, you find that there are so many prejudices or fears surrounding end of life discussions. Nobody would want to imagine that their next of kin is about to pass on, or even if they are imagining it, they don't want to be. Maybe you can be accused. Why are you talking about end of life in this case? And we are all optimistic that this person will recover, even where hope is lost, that we know the person is not going to recover. But people have those fears. So I think as a clinician, it would be important for you maybe to initiate the discussion where you find that the family members are aloof or they don't want to talk about it because it is important and they require that counseling or that information. You can try to prompt them, not to dictate to them that we must discuss this, but to prompt them so that you can be able to talk about it. Thank you.
Thank you so much, Doc, for response. Actually, it's better when the initiation comes from the ones who've reviewed the patients. They are able to advise or rather give a way forward to the patient. And the other question was from Kehpca, saying that he has a friend who is interested in specializing on palliative care and is asking for a sponsorship to it, and he's asking if there are any avenue. I don't know, Dr. Muinga, can you respond to that or share direction? The same.
Okay. In terms of training, it depends on what level they're talking about. specialized on palliative care. So I know the Nairobi Hospice has a training, higher diploma, palliative care. So they could start with there, and sometimes there are sponsorships for the same classes. I think the intakes are usually in September. So if someone from Nairobi Hospice is available on the call, they can add to that. Then the Nairobi Kenya Medical Training College also has the diploma targeting nurses. So it depends on the cadre of your friend. You could reach out then for further guidance on the same, but you could start from there, at least for the start of your certification. Thank you. Thank you.
Thank you, Dr. Muinga Kipkurui. I hope you've had the response, get the help that you need. Jared Bigot, your hand was up, kindly.
Mine is not a question actually, but it is a comment on Dr.'s presentation. She mentioned something about informal or non-formal caregivers. And I think that is an area which has been ignored. And I'm so glad. I was excited when she mentioned this particular group of caregivers. Those are the immediate family and those of us who do not have a background in palliative care, but we found ourselves in such a situation. So it is just a compliment. That is the direction to go. Looking forward to more engagements on this part of this section of caregivers. Thank you.
Thank you very much, Jared. And I'm happy that people are not only listening, but also reading through the presentation. Thank you for that. Yeah, anyone else? And Alvin and all of us, we are being reminded that the recording for this webinar will be uploaded on the Kehpca YouTube channel by next week, so you can always have access to it. Yeah, and also as we talk about research, we can also remember the importance of quality improvement projects, which can contribute actually to the research that we aim to do and even can inform practice in different institutions. So I hope I'm not leaving anyone behind. So we come to an end. 10 seconds just to ensure that I'm not leaving anyone behind. Anyone with a comment, a question? Okay. Thank you very much, everyone, for joining today's conversation. Then, as we aim at advancing palliative care in the country and beyond, and as you've been reminded today about research and the evidence thereof. So it's a beautiful conversation. Thank you so much, Dr. Mutinda, for sharing your presentation with us. We are very grateful. Before we wind up, kindly let me invite Roslyn. Kindly for a comment.
Oh, so that's me? Oh,
Good evening. Oh, sorry. Yes, good evening. This is Roslyn from Kehpca. Yes, just mine is to convey our sincere gratitude as Kehpca for, taking time to join into these important conversations that we have. And we just, it's very important what Dr. Mutinda is explaining today, or what the topic was today, because even as we see, even now, you see, Miss Teresa was asking where we can have, areas of collaboration. And I think it's a point that as all providers, we should think about actively, because research informs practice and also informs policy. So those are, I see Dr. Muinga, came up with the data that we have so far nationally. And as providers, the triad of research, practice, and policy is very important to us. So even as we rest for the night, let us see how much or where exactly we can plug with each other. And Kehpca appreciates you, and we continue to have, this series of webinars for the enrichment of palliative care in the country. Secondly, I know some of us were asking if we'll get CPD points. So far, we'd like to let us know that the CPD points that we have so far are for the medical doctors. We still have plans underway so that we ensure that the rest of the cadres have their CPD points. But in the meantime, we'll have certificates which will be shared with us on our emails, and we can use them to, process our CPDs in our, from our different regulators. That said and done, we hope to see much input coming out, matters palliative care, so that, when decisions are being made at the tables that matter, be it, ring fencing of finances, be it, purchase of health products and technologies, then there's a point from which we come. And we'd like to thank the Ministry of Health very much for taking the lead step. And Dr. Esther mentioned that for providers who'd want to engage in research, the doors are open. Kehpca also affirms that in case there are areas that we feel we need to research on, we are big on supporting our members so that we inform practice and we have better policies coming up. Otherwise, thank you so much, and we hope to see you next time.
Thank you very much for that. Dr. Mutinda, you had a comment?
Oh, no, sorry. I had as if you had mentioned my name, but I realized it was Rosalind. Asante sana. Bye.
Thank you so much, everyone. Have a blessed night and a great week ahead. And also Easter holidays coming soon. Bye-bye.
Bye. Thanks, and same to you.